afternoon, everyone, and welcome to the 21st episode of our Stop COVID Deaths webinar series brought to you by the University of the Philippines System and the Philippine Health Insurance Corporation. I'm Dr. Raymond Francis Sarmiento from the National Telehealth Center of the National Institutes of Health, University of the Philippines, Manila. And for those who are joining us for the very first time, ito na po ang ating second season for the Stop COVID Deaths webinar series. And for this second season, we will continue to utilize this really very new format, which we call the virtual grand rounds format. And this is the very first online medical grand rounds that we have in the country. And as always, thank you for joining us. And for those who are watching us in the playback, magandang umaga, magandang hapon, magandang gabi po sa inyong lahat. And I'm very privileged to share our hosting duties po with the dear friend and special mentor po for us all, Dr. Susie Pineda Mercado, who is the Special Envoy for Global Health Initiatives by the President Duterte. Dr. Susie.
Hi, Raymond. Magandang araw po sa inyong lahat. We'd like to welcome everyone to the webinar. It's a Friday. It's a day for learning and maybe capping the week with a discussion on something new. Right now, we already have capacity for 3,000 webinar participants. So I think we're leveling up, Raymond, and we'd like to welcome everyone who's with us right now and everyone who's watching on the playback.
Thank you, Dr. Susie. And I think a lot of our attendees are just now tuning in. There might be, I think, fluctuations in the internet connectivity for today po, ano? But for those who are already joining us and have joined us in the Zoom webinar room, maraming salamat po. And for those who are joining us again for the very first time po, ito pong ating Stop COVID Deaths webinar series is very different from the first season to this second season po, in that we are focusing on the dramatic personal stories of the patients as well as those of the medical team and the journey that accompanied po in how the patient was taken care of and how the global COVID-19 pandemic has really affected all of us, not just for the clinical management, but in all aspects po. Susie.
Yeah, you know, Raymond, I'm just looking at the chat box and we've got people from Cagayan in the north and Cagayan de Oro, Agusan del Sur, Bukidnon, so many places from so many parts of the Philippines, doctors, hospital administrators, medical teams, medical students are joining us. So it's great to be in this environment talking about what we're going to learn today. The topic is Barado at Sarado, very interesting topic that was created by the Department of Surgery to talk about a partial gut obstruction. So that's the condition of the patient, so Barado. Pero it's also about our system, our healthcare system, which has also become Barado and Sarado. So it's a good play on words, and I hope you're going to learn and enjoy this session.
Thank you, Dr. Susie. What we do here po sa ating virtual grand rounds is that we start off with a case presentation, and after that case presentation, we have a panel discussion with a discussant and several reactors po, as always, like previous episodes. And then we will entertain the questions coming from our audience po, no, for the Q&A session. But before we proceed, let me take this opportunity to thank all of the members of the teams and who are comprising this monumental effort that we bring forth every Friday po. It starts po from the University of the Philippines System and also our partners over at the Philippine Health Insurance Corporation, over at the National Telehealth Center, National Institutes of Health, and also at UP Manila. We also have our tech support provided by the UP Information Technology and Development Center. And yung pong nanonood po sa YouTube at yung pong talagang sumusubaybay, malaki po ating utang na loob sa TVUP, which is the Internet Television Network of the University of the Philippines. All of our webinars are archived, yung recordings po nila are stored and saved po sa YouTube channel ng TVUP. So doon nyo po mapapanood ang all of our previous 20 episodes. We will also like to thank Manila College of Medicine and the Philippine General Hospital for making this learning series very possible. Dr. Susie.
Okay, so we usually have a special guest to introduce the topic. And we've been inviting the deans of the different medical schools because this is really an effort for learning about clinical practice throughout the country. So it's my honor and privilege to introduce our introductory guest speaker, who is the Dean of the San Beda College of Medicine, Dr. Dino Fontanilla. Dean
Hi.
Dino, welcome to the webinar.
Yes, good morning. Hi, good afternoon, everyone. Yes, and thank you for inviting me to this activity today.
Thank you for joining us. And I hope the students of San Beda are watching today.
Yeah, I hope so too. I sent out the links. I told them to watch me.
Right.
Although
And
I
then
told them that
yeah.
I am just a small part in all this. No,
No, but actually, Dean, you know what we want to do eventually is have the other medical schools also present interesting cases. So we're starting out with the PGH cases, but ultimately, this is really an open invitation for all of our medical schools that are watching and hospitals. If they have a good case that they'd like to present, that you think others can learn from, we very much welcome your joining us. Anyway, Dean Dino, I visited San Beda once and I was struck by the words ora y labora.
okay.
Ora
Yes.
y labora. Prayer and work.
Prayer and work. Yes, that is how the Benedictine order has lived their lives. No, so yes, translated as work and prayer. But however, we do not consider it as two really separate things. No? They're actually part and parcel of each other. They're molded together. So we would like to think that our work is our prayer, and it's actually our way of sanctifying our life. No? We accept that life is full of difficulties and hardships, especially now with all this COVID. No, we try to find a meaning to what we're doing, or a reason why things are happening. But at the same time, we have to accept our humanity, that and accept all that is presented to us. No, and life is actually a pilgrimage of sorts, a journey towards finding God, and in the end, we hope that we reap the benefits of our hard work and of heaven. And with this motto of work and prayer, it allows us to endure everything. No? We accept our humanity, but we know that all these hardships greater glory of God. And I guess that's how we, the Benedictines, like to live our lives. No? Like in service to God.
Yeah, that's a great way to start our webinar today. I mean, we just think about all our frontliners and all the doctors, in fact, who are watching right now, who take this their Friday noon break off just to listen. That our work is a prayer, no? And I think we're all praying for this to come to an end, but also for strength to be able to endure it. Raymond, did you want to say something?
Oh, so it's been a long time, Dr. Dino. I remember that I think it was in 2018 when Dr. Susie and I first visited San Beda College of
That's
Medicine,
true. That's right.
and we were really interested with all of the innovations, your partnerships with Philips at that point in time, and we'd just like to hear po how the pandemic has really affected and corresponding response by San Beda in terms of transition to online medical education. How have you been doing in terms of all of the attendings, seeing their patients, ganun po?
Yes. So when COVID hit us in the first quarter of this year, no, it was like a thief that suddenly just stole our freedom, no, and we were forced to hide in our homes. No, even in the medical school, we could no longer access the campus. We had to do things off-site, no, and as you well know, we moved from ECQ, MECQ, GCQ, and back to MECQ again. And as early as March, when we went into lockdown, we initially thought we would only be away from our campus for a few weeks. No? And so we said, okay, let's just throw everything online. Let's give our PowerPoint lectures to our students, no? So that they can view it. We gave them reading assignments, plans for what they should study, with the hope that we would still have our in-campus exams at the end of the academic year. So sometime around May. Sadly, it didn't turn out that way, and April came, May came, and we were still online, and we were forced to even conduct all our exams online via Google and Classmarker. We proctored the exams using Zoom. It was not without its own difficulties and technical glitches. No? We were sort of, you can say, winging it at that point. But we survived, no? Our students and faculty alike, and we were able to end the academic year by June. However, sometime in May, with discussions with our faculty, we suspected that this pandemic was going to last a few more months and possibly towards the end of this year. No? So that was when we started to journey towards online education, and we started out by conducting a series of workshops in June. So we had a total of 8 sessions, which were held in the evenings, no? Via Zoom. We had speakers from both the academe and the private sector giving the talks. And our sessions were attended by over 100 faculty members. So I was really surprised. I couldn't get our faculty members to attend in-campus activities and faculty assemblies. But with the Zoom activity, they were all there. And maybe it was an advantage that they couldn't do anything except listen in online. They were stuck in their homes as well. So, of course, there were concerns from our students as to how we would do this online activity. They were worried. Of course, they were all expecting that we should still have our patient encounters. They were worried about the clinical skills that they would lose if we just did online teaching. And we had to organize some Zoom sessions with the students and the parents, discussing these concerns, explaining to them the current situation, the safety that's needed to be put into place for their sake, and that we couldn't really bring them to the hospitals at that point. And at the end of it all, I think the students and the parents did accept this. And so we decided, okay, we will now go online. After our faculty training, we did syllabi revisions. And for our clerkship, which we actually started in August, we decided to go with online case presentations. We had them attend the medical conferences, which were also online in the hospitals. And we had a telemedicine system set up in our community in Canosa, Health Science Center in Silang, Cavite. So that was where the rural health workers would conduct online consultations with our clerks and our faculty. This is our way of actually honing the communication and history-taking skills of our clerks. And we are currently in talks with some of our other affiliated hospitals in the hope that we could also establish a teleconsultation platform with them so that our students could still have that encounters with the patients. For the lower years, we actually invested in a lot of e-learning resources. Just recently, we subscribed for online physical examination. This delivers head-to-head system-based physical examination techniques for assessment in clinical medicine. We, in the past, already had the XR Clinician software. We acquired this 3 years ago, but we decided to purchase additional cases for this year for the use of our students. As we mentioned earlier, we already had a learning management system in place since last year, but we weren't really using it a lot. So this year, we plan to use it extensively. This is called Canvas, and we are also going to use this for some of our online exams. We've upgraded the internet connectivity in the campus. We've did surveys of our students and faculty who needs more gadgets and internet access, and we're helping them acquire those. We purchased an Anatomage virtual dissection table way back in 2016, and this one we also currently have now the capability to control it offsite. Our IT team had a workaround, and we were able to figure out a way to utilize it offsite, so our students can also view it. Other things, like digitizing our slides. We did have them already in higher resolution before, but again, only in campus. We're now transitioning to offsite access, maintained our subscription to Clinical Key and up to date. So yeah, that's so far how we've transitioned towards online learning. Do we have the right formula? Only time will tell. I don't really know. Will we succeed in our online learning? I hope so. I believe so. I think we can deliver quality education, but I think what we need to do is listen to our students, to our faculty. We need to collaborate very well. I hope we can also collaborate between institutions, UP, all the other medical schools. I think regular dialogue with our students is the key to success. It is a difficult journey, but I think if we work together, we can win over this and win over the pandemic. This virtual grand rounds is an example, and hopefully more institutions can join in and actively participate. So collaboration, I think, is really the key to this.
Great, Dean. We're really going to keep you in mind for a future activity that we're already cooking up, because we really want to do a very special conference on medical education and online learning, and we're going to keep you in mind. So your main message for all our participants who are listening now, I think we have about 300 people who are now in the webinar.
Okay. I think I did mention already earlier, but my main message, I guess, is that we should not give up. No, it is difficult. No, we've been hit so hard. No, but I think if we all work together, we collaborate well, we listen to each other. I think that is the key. No, we have to share whatever information we have. No, our experiences, our ideas. No, I think this is the time for everyone to just help out. No? It's not something that we should like just go on our own. I think that would be very difficult. I know some institutions are also trying to figure a way around this, but I think if we learn from each other, we can come up with a better solution for everyone. I think that's it. And I guess also the same thing I said earlier, work and prayer. We pray, we do our work, we accept what's handed to us, and we find a way around it, find a way to get through it.
Okay, thank you very much. So that's Dean Dino Fontanilla. Dino, you'll join us for the panel, I hope.
Yes.
And
yes.
we're looking forward to
yes.
your inputs. Yeah. Okay. So Raymond, I think there's some people asking again about the certificates.
So for those who are asking certificates, so yun po, it's become like a weekly tradition, but also we have been receiving your inquiries with regards to certificates po via email. The questions will really revolve around, will they be receiving certificates? So yun po, for those who are attending our webinar for the very first time, yes, we distribute certificates of attendance po for those who have attended our Zoom webinar at least 50% of the webinar duration, and for those who are asking for revisions or changes to the names, we'd like to inform everyone also who are watching this na yung pong name na i-input nyo po in the registration form, please be very very careful because that is exactly how it would appear in your certificate of attendance. So yun po. I hope everyone will take good care po in terms of inputting their names in the registration form. And I think at this point, maybe we could request TVUP to show our fun quiz. So as always, and just like in our previous webinars, we hold this fun quiz as a way to test our knowledge before the webinar starts, and then towards the end of the webinar, we ask the resource speaker who nominated these questions to give the correct answers as a sort of a post-test evaluation po of the knowledge gained after the webinar. For this particular webinar, we have two questions. These questions are being shown right now in the polls. The first question is, what is true of Crohn's disease? Option A, an inflammatory bowel disorder. Option B, a pre-malignant bowel disorder. Option C, affects a continuous segment of the large bowel to the rectum. And option D, surgery is the initial management. So we see a lot of our attendees keying in their answers, and hopefully we'll be able to get more attendees to answer the questions po. And then for question number 2, it states what is not included in the management of a patient with partial gut obstruction. Option A, hydration. Option B, antibiotics for bacterial translocation. Option C, large bore nasogastric tube insertion for decompression. And option D, application of abdominal binder. So sa ating mga nanonood, please keep on keying in your answers po. And as we move more and more towards our main presentation, okay, so we see now that based on the results, most of our participants, 85% who answered, they selected option A for what is true of Crohn's disease. And option A states an inflammatory bowel disorder. And then for the second question, ano po yung hindi included sa management of a patient with PGO, application of abdominal binder was selected by 79% of respondents. So please tune in, and then the correct answers po as mentioned will be relayed by our resource speaker towards the end of the webinar. But before Dr. Susie moves on po to the introduction of our main presenter, perhaps we could have this video that was prepared and produced by TVUP in order to set the context po for our case study.
"47-year-old Salvacion woke up with nausea and a bloated feeling. She had breakfast, but could not keep the food down. She vomited after every meal and had to run to the toilet because of diarrhea. Was it food poisoning, she thought. Deep inside, she was afraid that her symptoms were exactly as they were when she was 20 years old, when she was operated on for partial gut obstruction due to Crohn's disease, an inflammatory disease of the bowel, usually affecting the last section of the small intestine. At that time, she was rushed to the hospital and was operated on immediately. This time was different. COVID-19 resulted in the closure of hospitals around her. "Sorry po, sarado na ang ER," she would be told on the phone. Vomiting and watery diarrhea continued for 2 weeks. She knew she was losing weight as her clothes became loose. On the 3rd week, she was so weak she could not stand. She called a relative who was a nurse who came to her home and placed her on intravenous hydration. She looked at the days on the calendar. This was now 21 days of suffering. Finally, a private hospital admitted her. A nasogastric tube was inserted to decompress the bowels. On the 5th day of admission, a chest x-ray revealed she had hospital-acquired pneumonia and was started on antibiotics. But her symptoms were unchanged. She was bloated, vomiting, and had persistent diarrhea. She looked at her calendar again. 10 days had passed, and her belly was now visibly distended. She was transferred to a government hospital because she could no longer afford the costs of staying in a private hospital. At the emergency room, she was diagnosed to have a partial gut obstruction. "Barado po ang bituka ninyo. Kailangan maoperahan po kayo sa lalong madaling panahon," she was told. A swab test of COVID-19 was done. The next morning, she was wheeled into the operating room. That was only beginning to reorganize the systems for COVID patients.
Okay, a very, very interesting case at the very start of the pandemic. And we've got our presenter. I'd like to introduce Dr. Brent Viray, who is Senior Resident of the Department of Surgery of the Philippine General Hospital. Brent, welcome to the webinar.
Hi, good afternoon everyone.
Oh, Brent, ikaw ba nakauwi ka pa?
I can't hardly go home, ma'am. I just stayed at our dormitory po here at PGH. Most of
Yeah,
the
I
time.
know. I know the surgery residents really have a tough time, and particularly in this time of COVID. Uh, at the time when you were handling this patient directly, no, Brent?
Yes, ma'am.
And at that time in the story, they said they did a swab test. When you did the surgery, did you know if she was COVID positive or not?
During that time, we didn't have the opportunity to have the swab test at once po kagad. The results turned in just 4 days after the swab. That was 2 days after surgery na po.
Oh, goodness. So you went into surgery, and were you thinking that she might have COVID?
All of our patients that we operated on, ma'am, that we haven't had the chance to have the swab results po, we treat them as COVID suspect na rin po, or as COVID patients po, ma'am.
So you have to take a lot of precautions. All right, go ahead, Brent, and make your presentation. I think we lost.
Please feel free to share your screen, Dr. Brent.
Hindi po, sir.
Okay, so I think we're having some technical. There
There
we
we
go.
go.
Oh, okay, very good.
Okay. Can you see my slides now po?
Um, Actually, Brent, we can see the slides, but we can also see your notes. I think there
Yeah,
we
there
go.
we go.
Okay, so you've got. Oh, go back to the 2 seconds ago.
The slideshow.
Raymond, I think he can play from current slide, right?
Yes, yes, that is true. If
So
you
on
if you
the left
if you
side,
click
or
on
play
the
from this side.
icon, yes, that's true. If you click on the icon
Dr. Brent.
downstairs, Dr. Brent, yung parang cup that's next to the slider na may 34%, that's the slide show
The one that
function.
looks like a blackboard or a cup or...
Yes. Sa may
No,
baba.
lower right hand. There we go.
There we go.
Okay.
Yo.
You got it. You got it. Oops. Okay. Oh,
Then use slideshow. It's the one above next to tips. Okay. Dr. Brent, would you like TVUP to control the slides? Might be easier. So, okay. So while Dr. Brent is, okay,
there
there we
we
go.
go. I think we're good. Okay. Then just press enter. I think you'll go to your next slide. Press enter.
Sorry for the technical glitch po.
No problem. Go ahead. It
Start.
always happens. That's our new world. Go ahead.
Good day. This is Dr. Brent Viray from the Philippine General Hospital. I'll be presenting a case of gut obstruction in the time when healthcare access was instilled due to lack of hospital protocols and control of the COVID-19 pandemic. This is Barado at Sarado. Here's my presentation outline. The objectives of this presentation are divided into two, Barado and Sarado. Barado will talk about the clinical management of our patient and how our institution, being one of the COVID-19 referral centers, repurpose its resources to accept suspected and infected patients. While Sarado will tackle the social context encountered by a surgical patient and how healthcare workers in the community significantly contributes to this cause. This is a case of LS, a 47-year-old female. 22 years ago, she had abdominal pain and diarrhea. These were managed before as an inflammatory bowel disorder medically. Her symptoms progressed, and on 2003, she had abdominal distension without flatus and minimal bowel movement. She was admitted at a private hospital at Manila and had an emergency right hemicolectomy for Crohn's disease. She took mesalazine as needed and had infrequent consults with her gastroenterologist and surgeon. On March this year, she had worsening abdominal pain, weakness, easy fatigability, anorexia, with minimal flatus and watery diarrhea. However, it is good to note that the patient had no respiratory symptoms during this time. It is to be noted that the NCR enhanced community quarantine started last March 15, 2020. The patient went to a private hospital but was denied admission due to the lack of protocols for COVID-19. The patient returned home and asked her nurse relative to take care of her. The nurse administered intravenous hydration and pain relievers to the patient. However, the patient had worsening symptoms. Desperately, they tried their luck to another private hospital in Manila. She was admitted and was managed as a case of partial gut obstruction from postoperative adhesions. Conservative management was done, which included bowel decompression, hydration, and administration of antibiotics. A CT scan was done in another private institution due to lack of protocols in the hospital where she was admitted. Due to persistence of symptoms and the CT scan results, the patient was advised surgery on day 11 of admission. A routine preoperative chest X-ray showed right-sided infiltrates, of which hospital-acquired pneumonia was considered. Broad-spectrum antibiotics was started. Again, the patient had no respiratory symptoms. The patient requested transfer to PGH due to financial constraints. The patient was coordinated in the PGH command center for transfer. At the emergency room, the patient's NGT was replaced with a larger bore NGT, and a SARS-CoV PCR test was done as a protocol for all admitted ER patients. The admitting surgical team noted a piperazine tazobactam drip in the patient, and it was rechecked with the coordinating team that it was there for the patient's pneumonia. It is to be noted that the patient was endorsed as a case of partial gut obstruction only. The hospital-acquired pneumonia was not mentioned. The patient was transferred to the ER holding area for extraction of labs and further diagnostics, after which she was transferred to surgery holding area while awaiting surgery. On physical examination at the emergency room, the patient was alert, awake, coherent, not in cardiorespiratory distress. She was normotensive but tachycardic and tachypneic at 22 cycles per minute. Pertinent findings were crackles in the left middle lung field, and the abdomen had a horizontal surgical scar on the right lower quadrant, which was distended with hyperactive bowel sounds, tympanitic on percussion, and tender on palpation, more pronounced on the right hemiabdomen. Digital rectal exam revealed good sphincter tone, collapsed rectal vault, no mass palpated, no blood, no feces per examining finger. The laboratory's results were within acceptable range except for magnesium, in which correction was done accordingly. However, results of the RT-PCR were made available after 4 days during early times of hospital operation. Here are the chest X-ray of the patient. The chest X-ray revealed crowding of the vasculature with opacities in the right lung and with minimal blunting of the cosophrenic angle. Plain abdominal film revealed uniformly distended thickening and distension of the small bowel loops with at least 5 air fluid levels noted. The CT scan done in another private hospital showed anastomosis from the previous surgery had ill-defined enhancing soft tissue focus, and it has associated clustering at least 2 collapsed segments of ileum and proximal end of the transverse colon with wall thickening. Our impression at this time was partial gut obstruction from postoperative adhesion, status post, right hemicolectomy for gut obstruction from Crohn's disease, hospital-acquired pneumonia probably from COVID-19. So we did exploratory laparotomy, adhesiolysis, small bowel segment resection, and ileostomy. Intraoperatively, we noted the following. There were dense adhesions at the postoperative site on the right hemiabdomen. The transition point was at the small bowel adhesion at 140 centimeters from the ligament of Treitz, with closed loop obstruction up onto the ilium to the transverse colon anastomosis. Estimated blood loss was 1.2 liters, and the operative time was 4.5 hours. The patient underwent blood transfusion on day 1 post-op, and on day 2, the nasogastric tube of the patient was removed and was started on general liquids. During this time, the swab test of the patient was released to be positive. She was transferred to the repurposed COVID ward and was started on acyclovir. On day 4 post-op, the expected ileostomy output was high with watery consistency. Volume per volume replacement with oral and intravenous hydration and administration of pulverized loperamide and incorporation of latundan variety of banana in diet were done to control the output. Elemental oral nutrition supplement was also administered to ensure nutritional upbuilding. Electrolytes were also corrected. On day 9, the patient developed surgical site infection and was managed conservatively with wound care. A repeat swab was done for the patient. Again, the patient doesn't exhibit any respiratory symptoms. On day 14 post-op, the repeat swab result yielded negative, and the patient was discharged on day 17 with semi-formed ileostomy output and corrected electrolytes. The patient had regular remote consultation with the colorectal surgery teleconsulta and the online consultation request and appointment system. Currently, the patient had no repeated bouts of obstruction and controlled ileostomy output. So this was the first case done at the repurposed COVID-19 emergency room of the Philippine General Hospital. Please allow me to briefly and virtually tour you to this setup. The guiding principle of doing an emergency procedure in the COVID OR are to minimize exposure, maximize the resources, communicate and coordinate to perioperative health workers, and to maintain sterility at all times. Here are some of the pictures of the COVID-19 OR. A preoperative huddle is always done to coordinate the needs, expected time of operation, expected blood loss, anesthesia concerns, and anticipated problems during the course of the procedure. This made an efficient communication between among the perioperative team. This is the donning area where the team is supervised by a safety officer in wearing their protective equipment. This is the receiving area where the patients are accepted. Decontamination is done along the way of the patient all the time. This is the protective equipment used by the perioperative team. Here are the changes done for the COVID OR. This is the OR nurses station where the surgical team wait until the anesthesia team induces the patient. The engineering office created anterooms fitted to the OR door to decrease the spread of the virus. The anesthesia team ensures decreased risk by using clear aerosol boxes, and the hallways are always ensured to be decontaminated regularly. Additional operating rooms were repurposed. This is the doffing area where the perioperative team is supervised by a safety officer to ensure proper removal of PPEs. The storage area was repurposed to a shower area, and another operating room was converted to a dressing room. These initiatives ensure that the health worker is decontaminated prior to his or her exit to the COVID OR. This case is not without its perioperative challenges noted. There were delays in medical and surgical management due to non-acceptance of other hospitals due to the initial stages of the pandemic. During the patient's transfer, vital information was missed during the endorsement. Also, it posed risk to the transport team, receiving team, and the other patients in the receiving area. Intraoperatively, the surgeons noted increased fatigue due to heightened stress on operating a COVID patient. visual and tactile compromise are brought about by multiple layers of eye protection and 3 layers of gloves. These senses are vital to surgeons as we operate with the proper exposure, and dissection greatly relies on tactile feedback from the tissues. Discomfort from the PPEs cannot be discounted during the operation as an effective suit requires little penetrance of ventilation. In summary, this session presented the case of a COVID-19 patient with gut obstruction from postoperative adhesions managed surgically. During the pandemic, there were delays in management due to challenges in access to healthcare. Nurses in and out of duty are indispensable. Hospital resilience is a must to respond during the time of pandemic, and an emphasis on intraoperative decision-making and mastery of the anatomy are paramount to this patient's successful outcomes. As a final message, may we always remember the case of LS, where when we are dealing with all our patients vulnerable not only with their existing disease, but also in their access to healthcare during these trying times. Surgeons, internists, anesthesiologists, nurses, and paramedical health workers are all indispensable. Hopefully, even with the challenges of this pandemic, may we have all our access always bukas rather than Barado at Sarado. Towards equitable surgical access for everyone, again, this is Dr. Brent Viray. Maraming salamat po.
Thank you very much, Brent. That was a very, very interesting presentation. I'm sure our audience has many questions. I've got a lot of questions in my mind, and I think our discussion is going to be great. We've got, this is the way we're going to approach it, okay? So we have the chief of the Division of Colorectal Surgery who's going to talk about the colorectal surgery. We also have the chief of the Division of Trauma, who is incidentally the head of the COVID task force for PGH that helped reorganize the surgical teams. And we also have the Deputy Director of Nursing, because we really do want to emphasize the team effort, whether this is pre-hospital, during the hospital, and post-hospital context of the patient, that teams are really needed. So without further ado, let me introduce our discussant, Dr. Hermogenes Monroy, who is the chief of the Division of Colorectal Surgery. Doc Noning, welcome to the webinar, and please make your presentation.
Thank you, Dr. Susie Mercado, for the introduction. I will share my screen now. Oops, sorry. Okay. Good afternoon, everyone, and thank you for inviting me to participate in today's webinar. So my task is to discuss and focus on the clinical points of the presented case, and like to also share the PGH experience in terms of our emergency surgical data and experience. So we're given a case of patient, 47-year-old female with clinical intestinal obstruction in the time of lockdown early part in a COVID positive patient. There are challenges already identified by our presenter, Dr. Brent, which is very important. First and foremost is really protection during this pandemic, protection of the frontliners at the ER, and also the surgical team and the ward personnel who will take care post-operatively. And paramount to this is COVID testing or screening with RT-PCR in order to identify patients who will be placed in an isolation ward and dedicated operating room for COVID positive patients. And then if a patient is COVID positive, there will be some important measures to prevent infection of the frontliners in terms of pre-op, intraoperatively, and post-operatively. So there are tenets in the management of intestinal obstruction during the pandemic, which PGH has learned in terms of lessons and also best practices in foreign institutions. First and foremost, do not delay surgery in a patient with intestinal obstruction. So it's the same principle as pre-COVID times because of catastrophic consequences when you delay surgical intervention in patients with intestinal obstruction. We do routine PCR tests for all patients coming in at the emergency room with intestinal obstruction. Of course, proper PPE for the whole frontliners who will manage the case. In terms of surgery, every attempt should be made to minimize the blood loss and shorten the operative time and also decrease the possibility of an ICU admission because ICU beds are quite rare in terms of during this time because there are many COVID patients admitted at the ICU. And you also have to explain well to the patient and to the family that there's an added risk of nosocomial COVID infection, meaning patient can be infected post-operatively, sometimes at the ER from other patients and including the infected or asymptomatic frontliner. So just sharing to you one of the first published journal where PGH is a part of, published in Lancet, COVID surge. There is an inherent increase in terms of post-operative morbidity and mortality, both for elective and emergency patients when you have positive COVID infection. So in this series of 250 patients, mortality overall was 25%, 16% when it is an elective surgery, and 28% when it is emergency surgery procedure. And if patient develop pulmonary complications, mortality can go as high as 45%, almost 50%. So when we talk about intestinal obstruction, this entity is one of the most common conditions that we treat in the emergency room. And it can be small intestinal or involves the large intestine. The most common when it comes to obstruction is from the small intestine. And post-operative adhesions contribute around 70 to 80%. Also hernias. Crohn's disease is quite rare in the Philippines, but there is a note of gradual increase in incidence locally. There's also very few neoplasm of the small bowel. For the large intestine, colorectal malignancy is the most common cause of obstruction, followed by volvulus and benign stricture from diverticulitis and post-op radiation or post-radiation. So how do we go about diagnosing a patient with intestinal obstruction? So most patients will come in at the emergency room, and based on the history and physical examination, we can actually diagnose majority of the cases as having intestinal obstruction. This patient will usually have colicky abdominal pain, described as spasms or Tagalog hilab. Patient will usually have nausea, vomiting, and will have decreased frequency of bowel movement and flatus. On physical examination, usually focus on the abdomen. The abdomen is usually distended, especially if the location is more distal in terms of the intestine. There will be usually on auscultation, there will be hyperactive bowel sounds. Abdominal tenderness and signs of sepsis can be found if the patient or the intestine is already complicated, meaning strangulated, perforated, or ischemic. The initial diagnostic examination is usually plain abdominal x-rays where you can find dilated bowel loops, differential air fluid levels, and possible pneumoperitoneum if the bowels are already perforated. But right now, in most advanced institutions, CT scan of the abdomen with contrast is the main examination of choice because it has the advantage of showing the level of the obstruction, the possible cause, and even the severity of obstruction. So in this patient, we have the following abdominal X-ray films. You can see this is the first film is the upright film. You can see different loops of bowel with air and fluid leveling. So we call it differential air fluid levels when there's a difference in the level in a loop of bowel. And on supine view, you can see the distended loops. These are small intestinal loops, probably measuring more than 3 or 4 centimeters already at this point when the patient came in at our emergency room. So these are danger or warning signs of impending perforation or ischemia. So CT scan, you can find actually the point of adhesions, especially with contrast, whether it is in the mesentery, sometimes in the abdominal wall or in the pelvis. And you can also see some signs of late obstruction, stage of obstruction, like fecal sign or feces sign, which is a sign of complete gut obstruction, which is also a danger sign or indication for surgery. And you can also find non-contrast enhancement of the bowel wall, which signifies ischemia of the bowel. So how do you manage intestinal obstruction? Of course, when the patient came in our emergency room, I think patient has already been managed for a few days, at least 10 days in another hospital. And at that point, patient was already for emergent surgery. So the patient has signs of possible complete gut obstruction, possible ischemia based on the findings of abdominal tenderness on palpation, and also abdominal distension and absence of flatus and bowel movement. So when a patient comes in at the ER with and diagnosed intestinal obstruction based on history, PE, diagnostics, then you have to decide whether the patient has indications for emergent surgery, meaning surgery done within 24 hours. So these are the following indications of patients will need emergent surgery when patient has peritonitis, perforation, ischemia, strangulation, complete or high-grade obstruction, or patient has incarcerated the hernia. If the patient doesn't have any of those signs and symptoms, then patient can have a trial of non-surgical management, usually in patient with adhesions and a patient also has a partial obstruction, and patients in a palliative setting of recurrent malignancy, then you can still do trial of non-surgical management. So for post-op adhesions, this was published in the World Journal of Surgery. They suggested the following algorithm. So if patient has signs of strangulation, peritonitis, and early surgery, no resolution of after 72 hours of management, then you do surgical intervention. But conservative management can be done using nasogastric tube decompression, IV hydration, electrolyte correction, and in our institution, we give IV antibiotics and observe. Some patients can be given oral contrast, water-soluble contrast like gastrografin. And if the contrast is visible in the colon in less than 24 hours, you can start to feed the patient, meaning the obstruction can resolve. If there is no resolution within 72 hours or there are recurrent symptoms of obstruction, then you can proceed with surgery. So what's the difference in management of intestinal obstruction during the pandemic? basically the principles are the same, except that you have to, of course, factor in the possibility a patient has COVID. So at the ER, we do RT-PCR tests, and fortunately, we had the turnover around time now is only 3 hours after test swabbing, and we can isolate the patient if positive. And if negative, but you still suspect that the patient has COVID because of other symptoms like respiratory symptoms, then we can admit the patient at our COVID wards. And then, just like the previous algorithm, so you determine if the patient needs emergent surgery based on your clinical examination. If not, then proceed with the trial of non-surgical management. And if you need to do the surgery, you have to do it in a designated COVID OR, whether patient is COVID positive or suspect. So what are the important points in the surgical management, especially for surgeons? Best surgical judgment should be applied all times. The most senior or experienced in the surgical team should perform the procedure to minimize blood loss, to shorten the duration of procedure, and decrease the risk of being admitted at the ICU. So training is set aside, particularly in the initial phase of the COVID pandemic. And the most senior is assigned as or designated as the surgeon and not the junior resident. So shortest possible operative time with least blood loss, minimize risk for complications and ICU admission. If you are to use electrocautery, you have to set the setting at a very low voltage. And if it is available, it's advisable to use smoke evacuators because of aerosol generating. It's considered as an aerosol generating procedure when you use electrocautery. And you should have a low threshold as a surgeon for diversion or non-anastomosis, because post-operative leaks or complication will probably lead to ICU admission. So I would like to share our emergency surgical experience in PGH done at the PGH COVID OR from April to August. So we did 237 patients at the COVID OR, peaking in July. And we still do a good number of patients at presently. So the most number, you will be surprised, is from obstetrics, only followed by general surgery, where we belong, the department of surgery, and also TCVS, orthopedics. So this is the distribution of the monthly utility of the COVID operating room. So OB, because there are a lot of COVID positive patients who will need cesarean section, and very few hospitals in the Metro Manila accept or admit patients for delivery, particularly for cesarean section. So as you can see also, there are a number of operations for intestinal obstruction that we did, both for adults and pediatrics. And there are other cases like for vascular access, appendectomy, also for ectopic pregnancy and complicated gynecologic procedures. So most of the patients are COVID positive, some are suspect, and only 2% were operated negative, but probably considered suspect. That's why they were done at the COVID operating complex. So in the Department of Surgery, this is our experience, almost the same as the COVID surge data that was published in Lancet. So out of the 31 patients that the department did, 9 died for a mortality rate of 29%, and 7 died from acute respiratory failure and pneumonia. The 2 others died from cholangitis and liver injury. The majority are female, mean age of 58. And we also did patients who recovered from COVID, either mostly as electives, and still the mortality rate was quite significant. 5 of 33, 15%, and 4 from pneumonia, 1 from sepsis. This time, majority are male, mean age of 47. I think that's the last slide. So thank you for your attention.
Okay, thank you. Thank you very much for that excellent presentation, Dr. Monroy. We have more questions. No, I really appreciate your entire presentation on surgery that's been done in PGH. As a public health person, for me, it's fascinating that you have so many obstetric cases for surgery. But I think there are lots of questions that are going to come out of your discussion. I thought it was a brilliant presentation. Thank you very much, Dr. Noneng. Okay, we've got the reactor, and our reactor is Chief of the Division of Trauma, but who's also the head of the COVID task force of the Philippine General Hospital, and was behind the reorganization of not just the surgical wards, but I think the whole hospital. So I'd like to welcome Dr. Orlando Ocampo, or Boc. Boc, welcome to the webinar.
Can you hear me?
Yes, I can hear you.
Okay.
Yes.
So I need to
Boc,
wear
is
mask.
it okay?
I'm in the.
Okay.
Is it okay?
Okay. It's fine. Go ahead.
It's okay.
Go ahead. Go ahead.
Okay. Thank you, Dr. Susie and Raymond. I would like to thank the organizing committee, and of course, I would like to congratulate both the discussants, Brent and Noneng. So, as part of the COVID operation, I really appreciate all the problems cited in this presentation. What I will do now as part of my reaction is actually to enumerate those challenges and provide solutions, either theoretically or maybe cited some existing guidelines and protocols done by the PGH COVID Crisis Committee. So I think clearly one of the identified problem is the access block. The non-COVID patients can't enter as easily as pre-COVID, any hospital. And unfortunately, PGH was branded as a COVID referral center. Parang natakot lalo yung mga pasyente na, COVID ang PGH, baka hindi sila tumatanggap. But truly, we never close our hospital, even to the non-COVID patients. So as evidenced by this, nung nilipat sa amin, tinanggap naman namin. Although there is really some stigma on being labeled as a COVID referral hospital. Well, the second problem is, I think, the coordinated transport. I really appreciate the relative nurse who took care of the patients at home. Parang nilagyan ng IV. Of course, this won't suffice kasi yung pasyente needs a facility. Siguro, kailangan siyang ma-admit sa ospital. And then hindi alam ng nurse, o buti nga may nurse hindi alam kung paano pa-admit yung pasyente. And I think the government responded to these two problems, access block and coordinated transport, by developing what we call now the One Hospital Command. Now, with the public announcement of the One Hospital Command number, I think patients now has at least has an access to be admitted to any hospital based on the assessment of the One Hospital Command. So I hope the One Hospital Command can develop the inter-hospital transfer, and I think they are actively doing that now. So I think the challenge of access block and inter-hospital transfer is partially solved by having One Hospital Command. Now, I also appreciate during that time, early on, this is April, we opened March 30, the delay in the swabbing result. I still remember my first swab came out 1 week after the swab. And I can't imagine an emergency case waiting for their swab for a week, and that won't happen, right?
Yeah.
So our institution actually really made an effort so we can come up with a machine. And fortunately, we have several donated machines now. And I'm proud to say we're producing results sometimes within the day or 24 hours. And we are actually proud of having what we call the BD Max machine. BD as in boy dog machine, BD Max, which can produce result in 3 hours. And this is very applicable in this case because I can imagine a patient who will be operated in a COVID operating room who doesn't deserve to be operated there because of, lack of results or lack of swab testing result. Now, if this patient will arrive at this time, I'm pretty sure this patient will have a BD Max and can be operated in a non-COVID OR instead of what happened before. So I hope you appreciate the changes now that we're actually instituting. And having a delay in the result will mean longer stay at the emergency room. Our emergency room, of course, we admit PUI before and now what we call them suspect, and we test them. But during those times wherein the results are delayed, there is actually a chance that this patient might get infected by another patient who is also a suspect. So looking at the angle, this patient stayed at the ER for 4 days. So nag-positive ito nung naoperahan na sa ward. Saan niya kaya nakuha yung infection? So we can say that one of the angle is nahawa siya sa isang pasyente din na nasa ER. It turned out to be positive and who knows. Or nahawa siya sa watcher. Yeah. Who knows? So I think at this time, starting a month ago, we're swabbing the bantays as well, the watchers. So that would actually an extra safety measure that we instituted just to make sure na if we admit the patient in a non-COVID ward, even the bantays or the watchers are also declared non-COVID. So, and I can imagine the panic and chaos it created when the patient was admitted in a non-COVID ward and turned out to be positive.
Mhm.
I still remember yung panic na yon because lahat ng nurse namin, lahat ng doktor gustong magpaswab dahil exposed daw sila doon sa pasyente and all. And I think we solved that now having the BD Max and having swabbed the bantays as well. So hindi na kami napuputukan sa ward ng positive. And I hope other institutions can learn from this lesson na siguro truly if you label the patient non-COVID, all of the employees there, healthcare worker, are truly negative as well. Well, I can't overemphasize the role of nurses here, in and out of the hospital. And I know Ma'am Cecil Peña will discuss this, so I won't dwell on this anymore. Overall, I noticed that COVID-19 actually offered so much challenges, but I would like to thank and I really appreciate our PGH crisis team who are always flexible and proactive to accommodate these changes, which sometimes happen on a daily basis. So as my director say, towards the end, our policies, guidelines, and everything we do is always guided by science. And our foremost goal up to now is always the safety of our healthcare worker. Again, thank you, Ma'am Susie, Raymond, and all to the organizing committee for this opportunity.
Okay, thank you very much, Dr. Bok Ocampo. Very nice analysis of the case, the discussion, and you brought out several very important points about the management, about questions about how the patient actually got infected, and the role of the team, and what the setup, the importance of having uh, results right away from RT-PCR testing. Okay, so stay with us. We're now going to call on Ma'am Cecil Peña, who is the Deputy Director for Nursing in the Philippine General Hospital. And Cecil, welcome to the webinar. In this story, there was a relative nurse who took care of the patient when everything was sarado. And I think I mentioned this in one of our planning sessions that in the 1918 pandemic, nurses were actually being kidnapped because people were, desperate for any kind of support that could be given by a trained professional. So, Ma'am Cecil, what is your view on this case and the role of the nurses in the pandemic?
Yeah, thank you, Dr. Susie. Good afternoon to all. Now, this case, actually, I will react on the two areas where the nurse was involved. One is in the community, and when the patient has been admitted in the hospital for operation. So first, the case actually presented a challenge as the nurse started an IV fluid to a relative whom he may have assessed to be severely dehydrated and requiring some form of immediate attention. And in this case, there was no other person who can help the patient because emergency rooms were closed and the pandemic is there. And as Filipinos, we are known to have a closely knit family. Once a member of the family gets sick, the tendency is actually to offer the best help possible. And I would like to focus on the Filipino value, which is actually putting the family as the center of care. And for this particular situation, the patient is the center of the care for the Filipino community. Now, there is the valued trait, which is considered for this case, which is on positivity, flexibility, and adaptability. In the community, the patient's family will always think of the immediate person who is actually a nurse to be one of the persons who can help them out. And the nurse relative actually may have thought that it is an anticipated help to provide relief. For community nurses, actually, they are well trained in basic intravenous therapy. And as a trained IV therapy nurse, they can do insertions of peripheral IV lines, and at the same time, starting on an IV infusion. Now, in this case, the nurse has conducted actually an initial assessment and the plan of care. And of course, basic requisite, whenever an IV is started, there should always be a written order from the physician. However, in this case, the nurse actually performed, we call it a heroic act, because he decided to start the IV fluid so that this patient will be able to have an improvement, at least in the nourishment. So the nurse actually learned how to deal with the complexities arising in every patient situation and constantly find ways of preserving their caring practice. And I would say it is an essential part of nursing education in providing nurses with the skills to identify vulnerable population and their diverse healthcare needs, as well as making decisions. So in this particular case, the nurse actually take on the responsibility of giving the best possible help. So the nurse promoted health and higher level of functioning when actually they go on what we term as a person-to-person relationship. And the nurses actually make up the largest workforce within our healthcare system. And the nurse is actually the first person present to provide care, especially during periods of crisis. Now, in all of its forms, the advocacy of the nurse was to ensure that people, particularly those who are most vulnerable in society, are able to have their voice heard on their healthcare needs that are important to them, defend and safeguard their rights, and have their views and wishes genuinely considered when decisions are being made about their lives. Now, in the second situation, the role of the nurse may have actually been missed out as the patient has been moved from one hospital to the other. With this patient undergoing Explore LAP, small bowel resection, and ileostomy, the role of the perioperative nurse, that's the way we call the nurses in the operating room, they actually provided care for this patient while the patient is still in the holding area, and during the actual operation where the nurse actually performed either as a circulating nurse or a scrub nurse, and post-anesthesia care immediately after operation. Now, despite actually several training and implementation of standards, patient safety issues actually continue to be of concern when it comes to perioperative care. And of course, the problem of what we termed as intraoperative injuries may lie actually on the nurse's implementation of safety measures that require critical thinking. And it is necessary to provide adequate support for perioperative nurses to perform their role in an intense, distressful environment. Now, both the community and the perioperative nursing situation, critical nurses or critical measures either were performed by the nurses. And this will include, first, working closely with all in healthcare team members. So the nurses worked side by side with the doctors through huddle to determine essential versus non-essential surgeries, analyzing potential scenarios and outcomes. Second, open communication is vital. Now, through every phase of planning and preparation for any patient who will be admitted and be operated on, nurses are closely working with the teams, conducting rounding, transparently communicating, and educating. Daily meetings are actually conducted to discuss challenges, issues, and concerns. And the best way for the nurses to enhance relationships is actually, during this time of crisis, is through constant open communication. Third, the gift of time is invaluable. As soon as PGH was identified as a COVID referral center, we need to think actually about the gift of time. Do we have it, and how do we take advantage of it? Movements need to be made immediately, every minute of the available time. Coordinating skills of the nurses for vacancies, schedules of operation, helping resolve perioperative challenges like the most frequent discomfort of the level 4 PPE. Fourth is leading by example. This is extremely important, especially in the crisis or pandemic. Now, if nurses are temporarily transitioning from the operating room, post-anesthesia care unit, and the ICU, nurses need to have the knowledge of how to handle every unique patient situation. Now, the supervisors and the head nurses usually meet with their teams to assess about their comfort, confidence levels, and of course to determine and ask each nurse how they are and how can they be helped. Now, fifth is to remain connected. So nurses began taking on new assignments. They were assigned as safety officers, and they go on different shifting schedules, morning and night shift. There are also changes in the work environment, which the nurses are able to adapt. Changes are also done in their clinical assignments for borderless staffing. So nurses in the OR and PACU, they relieve in ICU work, and some of the nurses in the wards are kept updated through Zoom meetings, through emails, or through text messages. And the sixth critical measure of both the community and the perioperative nurse is providing flexibility and support. The situations in the COVID area actually evolve rapidly. So nurses usually look to their leaders to gauge their emotional barometer. A listening ear from a colleague usually provided emotional relief. Nurses had to be flexible as they worked through how to continue to provide an appropriate level of support while also providing nurses with the critical training on the job. You know, we have to juggle assignments of nurses from one area to the other just to complete the number of nurses to take care of our patients, both in the COVID and in the non-COVID areas. And finally, actually, it is definite that clear lines of communication among nurses are essential to promote shared understanding, increase engagement, and reduce clinician stress. And influencing a positive culture, which we always say we need to embrace change to potentially improve the quality of care that we give to our patients. In closing, I'd like to give you this ending message that when you are a nurse, you know that every day you will touch a life or a life will touch yours. So thank you for giving the nurses the opportunity to be heard in this particular webinar.
Thank you very much, Ma'am Cecil. Of course, not just an opportunity to be heard, no, we would really like to emphasize the importance of teams in the management of patients and the outstanding work. We are grateful for the outstanding work of all nurses in the country who are frontliners who actually get their fair share of infection from taking care of patients. Okay, so we're going to call everyone back into a panel. And I would just like to acknowledge the presence of UP Manila Chancellor Menchit Padilla to join us, Dean Dino Fontanilla, of course, Dr. Brent, Dr. Nonong Monroy, and Dr. Bok Ocampo, and of course, Raymond. So I think we'll have everyone, and Ma'am Cecil. So we have everyone now on the panel. And Raymond, your first shot at the discussion.
Actually, this question po is really for Ma'am Cecil, and it really goes into the legalities of what the nurse can or cannot do during this pandemic. The question that we have here is a question that we have also received offline, and the question reads, in this scenario, what are the legal implications for a nurse who starts IV therapy without a doctor's order during this pandemic po? Ma'am Cecil.
Yeah, thank you, Doc Raymond, for that question. Actually, the nurses can start an intravenous therapy provided they have undertaken what we term as a basic intravenous therapy training program. So that is complete with didactics and workshop. And the nurse is given actually a certificate of training, and the Association of Nursing Service Administrators of the Philippines and all the government and private hospitals who offer this program issue a certificate of training, at the same time an ID that they can perform such. So if they have or if they possess this particular certificate of training and certification from the accredited professional organization, then the nurse can practically insert a peripheral, a peripheral IV line and start an IV fluid solution.
Okay, I'm gonna pick that up a little bit, Raymond, because Chancellor Menchit is with us, and I'd like to sort of get her thoughts on this. In the context of a pandemic, which is actually like a war, questions about legality of practice, of course, an ethical practice is very important, but I think I would like to hear Chancellor's view on how we actually respond to situations when we need to save lives.
Well, in extraordinary times, you will have to live up to what is expected of you. Like even if you're not yet for a doctor or even a medical student. So even when you go back to World War II, I was reading the excerpts during that time when you are you have to practice your profession. So I guess, because now there is room for guidelines, maybe what we can do as an institution is probably to come up with guidelines so that the people in the community can be guided. That's the only thing I can see for this case. Because if you look at the story of this patient, the nurse relative felt it was her responsibility to respond to a problem which the hospitals were not willing to take on. So how can you fault this nurse? But I think she has to know her limitations. And at one point, she will have to connect with a physician. Maybe there's something different now as compared to March because we have the telemedicine now. So maybe my recommendation now to the community is that if you're caught in a case wherein you need help, of course, the PGH doctors and the doctors in the other hospitals will be more than happy to pick up your call and guide you properly. But it's
So
so hard when you're at war. It's so hard when you're at war because uh, you don't have the ordinary rules, and when you're in the middle of a war.
yeah, thank you very much, Chancellor Padilla. I think, Nejit, I think the thing is, it is a new normal and it's going to be a persistent new normal. And the demand for services is actually quite high because of the fear of going to hospitals. And so I think it's great that we can think about guidance on how we actually respond. I mean, it's almost like emergency medical care or first aid that um, in a situation where access was already very difficult prior to the pandemic, but more so now. Anyway, so let's go back to our case, and I just wanted to ask Brent because I saw one of your pictures, and you were actually your scrub suits were wet. Am I correct? Was that perspiration when you came out
Yes,
of that surgery?
yes, ma'am.
What? Okay, Brent. What was this experience like for you? What were you feeling?
Uh, because the PPEs are very, of course, a good PPE has minimal ventilation po for proper protection. During the operation, we are really stressed because of the discomfort of the PPE. And after which, we were full of perspiration na rin po namin. Tapos yung stress pa that you're probably at that time operating on a COVID patient, talagang heightened lahat po ng senses. Kaya medyo mas extra challenge during that time.
You know, Dean Dino is an ophthalmologist, and I was going to ask him a little bit about eye protection during surgery. And I think Brent, in your story, you were saying that tactile feedback is very important and visual feedback as well. So I don't know, maybe Dean Dino, you want to comment a little bit on that, on the eye protection part.
Right, and actually, in our field, no, that's been a problem. We've been trying out different goggles. Face shields work, but unfortunately, when we start examining our patients in the slit lamp, and when we do surgeries using our microscopes, the face shields we can't use them. We have to use goggles. Some of my colleagues are okay with the commercially available goggles. I find them causing a lot of fogging. So that's one issue. Some of us have invested in a slightly more expensive eye protection, which has more or less minimized the amount of fogging. But we do agree that we do have to wear eye protection. There are a lot of reported cases of COVID-19 presenting as just conjunctivitis, no? And so we really have to do all that we can. Tactile.
Actually, yeah. Go ahead.
Yeah, no, with regards to tactile, no, again, when we do surgery, especially in our case where we need fine motor tactile feedback, so unfortunately we have to use, most of us agree that we have to use double gloves, no. But I think we have to just make do with it, no, just to add that additional layer of protection when we do our surgeries.
I mean, I think I heard Brent say triple gloves, and I'm gonna ask Dr. Monroy to comment on that. What is it like to do surgery with triple gloves, Dr. Monroy?
Well, it's not only the tactile limitation, but even the movement of your hands and
Hands.
fingers will be affected or limited. Well, right now we advocate, that was the on the initial phase of the pandemic. So we tend to overdo things, so triple glove. But now we recommend just double gloves for COVID, but still there will be some limitations. For non-COVID, we can use the usual single gloves for protection.
You know, you said something in the discussion which just stuck in my head, and I think I'm going to ask the others to comment about this, how important decision making is, particularly when you're looking at surgical emergencies. Would you like to expound on that, on the decision making? So you were saying that, you know, you have to have the most senior, the most experienced surgeons there, and making that decision in a timely manner is very important. Could you talk a little bit more about that?
Yes, ma'am. During this pandemic, there's tendency to delay, particularly surgical interventions, and then there was some literature recommending non-surgical management for intestinal obstruction. But with experience and lessons learned in our institution and also from published journals, there should be no delay in terms of diagnosis, in terms of decision making, the timing of surgery, and therefore surgical judgment and experience will come into play. And during this pandemic, the most senior should be the one. We that's our policy. Should be the one to do the procedure, because if the junior residents will do it, there will be increased operative time, sometimes
Right.
even blood loss, and
Yeah.
therefore patient can be put at risk in terms of being admitted at the ICU. So ICU is very precious during this time. So we try not to have our post of patient admitted at ICU.
Great. So I think that was the connection there. No, you want to make sure that everything goes well because you don't want to compete with the ICUs that are needed for COVID. Raymond, did you want to ask something?
So the questions po will be relating to the challenges for surgeons po. And the first question that we have is from Ma'am Cecil Pulido. What is the PGH experience po, Dr. Monroy, Dr. Bok, or Dr. Brent, with regards to patients who have been confirmed COVID cases, and then in the course of their admission would eventually require surgery? Has there been any cases of that note po?
Yes, Raymond, we have patients, usually elective patients for surgery, and then we swab and turned out to be positive, either mildly symptomatic or even asymptomatic. We just delay the surgery, either admit the patient or put them on quarantine in a quarantine facility. And once the patient is no longer infectious, which usually 10 to 14 days after being tested, then we can schedule the patient for elective surgery. We have those patients.
Okay. Doctor,
Dr. Noneng,
go ahead. Go ahead.
yes, for the next question po would be, it's very interesting actually. Has there been any instances wherein a patient due for surgery refuses to undergo RT-PCR? How's that usually handled if that has been experienced in PGH po?
Well, we don't have, I think it's mandatory. I think the only patient that the patient that refused swabbing was a psychiatric or schizophrenic patient, but it's a non-surgical patient. So for all our surgical cases, it's really mandatory for them to be swabbed.
So I think there's a greater acceptance already of this. Dr. Bok Ocampo, I was going to ask you, I thought that was really a very interesting intervention that you've introduced, that the watcher, so yung bantay, nasa swab din sila. Can you tell us a little bit more how you do this, no? Because we're talking about waiting time in the ER and how one could get an infection from that. if a patient is about to be admitted, do you swab one bantay and one patient? How do you do this at the Philippine General Hospital?
Thank you, Ma'am Susie. Actually, we have two types of patient. One is the group that will undergo elective operation. So we usually swab them 3 days before the scheduled operation, together with the watcher. And we have a bad experience of the patient having a negative result, but the watcher is positive. So since this is an elective operation, and they are living in the same household, we presume that maybe that elective patients will undergo surgery is positive as well, baka false negative lang. So we postpone the operation.
Right.
And
so
then the other group, yes. So the other group are the emergency patients who are actually groups into two as well. Alam niyo yung trauma patient na who can't wait kasi mamamatay na sila. So these patients will be swabbed immediately. And then iaakyat na sa operating room o operahan na. Of course, if we use BD-Max, after the operation, we know, after usually 3 hours, lalabas na yung result. Alam namin, at least saan sila admitted, sa non-COVID ward ba o sa COVID ward. The other type of emergency cases are, let's say, appendectomy patient, appendicitis, wherein the patient will be swabbed and can wait for the BD-Max result. At least these patients can benefit from being operated in a non-COVID. Used to be like this case, di ba? Kung ang resulta lalabas pagkaraan ng 1 linggo, walang choice kung hindi operahan nito doon sa COVID OR, which is actually unfair. And I would like to add this. Brent vividly described to you what will happen in the COVID operating room. You will wear level 4 PPE, magmi-misting yung lahat, and then naka-double gloves ka. I mean, all of this problem was solved eventually by having that result come out immediately. So we rarely do now COVID operation. I mean, operation do sa COVID OR unless talagang trauma patient na emergency o talagang COVID positive. So I think that's one of the advantage of that machine that we had. And I'm not really sure if other institutions are also having donated machines like that.
So thank you very much, Dr. Boco Campo. I think through this webinar, we've been seeing how slowly but surely we are becoming better at managing cases, whether they're COVID, non-COVID, and adapting our hospital setting to that. Ma'am Cecil, I was going to ask you, our nurses in PGH, how long do they go on duty? This is a question that's come up.
Doc Susie, our nurses are divided into 2 areas of assignment. So one group of nurses, they are assigned in the COVID areas, and the other group is in the non-COVID areas. For those in the COVID areas, the nurses are reporting 7 days a week, but they go 7 days off. But within the 7 days, I always tell them, have a 1 day off in between so that they are able to rest. And those in the non-COVID, they go on every 15 days shifting schedule. So eventually their off days are only 4 days, given a 40-hour per week work schedule. So their duties are on the morning, afternoon, and night. And the changes are every 15 days for non-COVID. And for those in the COVID areas, they also go on shifting schedules morning, afternoon, and night. The only difference is that they go straight 7 days. So
Okay,
that's it, Dr. Susie.
So yeah, very important to be able to manage our human resources in such a way that we avoid burnout, fatigue, and we're able to maintain a high level of energy for everyone. Raymond, I think we can take 1 or 2 more questions from our audience. What are your most upvoted questions?
So I think we already answered the most upvoted question po, no? I think one of the more important questions would be, how is the patient now, Dr. Brent, with regards to post-op follow-up? How did you conduct that for the patient?
For the patient, sir, the patient has frequent follow-ups with our teleconsulta avenue po. In which ngayon, sir, wala naman pong bouts ulit ng obstruction. The ileostomy output, which is expected to be in high output po, since it's 140 centimeters from the ligament of Treitz only. Is managed with loperamide and volume per volume replacement orally. So very happy naman yung patient, sir. So okay naman siya.
Great. Okay, Raymond, maybe we can go to the answers to our fun quiz.
Thank you, Dr. Susie. I think we lost you there for a while. Perhaps we could go to before we go to the polls po. Let's just have one more question, and I think one of the questions po will be well, it's directed to Dr. Bok because of the question. The nature of the question is, if watchers of the patient will be swabbed, is that out-of-pocket expense or is that still covered by PhilHealth po?
Nice question. It's always free. We actually swab the charity patients and the watchers. Laging libre. Ang may bayad lang naman dito yung nasa pay. But all of them are free, including our healthcare worker and all the frontliners from other hospitals as well.
Okay.
Yeah,
Thank you,
I think that,
Dr.
yeah,
Bok.
Raymond, I just wanted to say, I mean, I think that should be a goal of the health system, that the testing for COVID should be free. It's
Not just free, but
free.
fast din po yung results.
Fast and free. Correct. Go ahead, Raymond. Sige, let's go to our poll.
Okay, thank you, Ma'am Susie. Can we have TVUP display our poll questions? Okay. And ask our attendees to answer them a sort of a post-test. So for our poll po, we have two questions. Both questions were nominated by our case presenter, Dr. Brent Viray. And the first question po is, what is true of Crohn's disease? And the answer, Dr. Brent, is?
The answer is letter A, an inflammatory bowel disorder. Congratulations for the 85% of the people who answered it. 111 people.
Raymond,
Okay.
sisingit lang ako ha. Sabi ni
Sige
Doc
po.
Dino, meron daw eye complications minsan yung Crohn's disease. Doc Dino, you want to say a few sentences on that?
Yeah. So yeah, Crohn's disease is actually very rare, no? But in possibly anywhere from 2 to 12% of patients who have Crohn's disease, some of them would actually manifest with eye findings like conjunctivitis, scleritis, uveitis. No? And so actually, when we have patients who are uveitis in our checklist for in the history, one of the things we ask is if the patient has any bowel disturbances. So this is a default question in uveitis.
Wow.
Because we're trying to rule out they have inflammatory bowel disease.
Great. We learned something new about having a multidisciplinary team. Okay, Raymond, the next question.
Okay, for the next question po, what is not included in the management of partial gut obstruction? The answer, Dr. Brent?
The answer is application of the abdominal binder. It's not included in the management of partial gut obstruction. The tenets are, of course, hydration, antibiotics for initiation of antibiotics for bacterial translocation, and insertion of an NGT or nasogastric tube for decompression of the bowel.
Okay, and we do have an evaluation, Raymond.
Okay, so for those who are still on the webinar po, we have this evaluation with regards to the discussion that has recently transpired and how our panelists have demonstrated, well, the following: thorough knowledge of the case study, their level of preparedness and organization Clear and audible po ba yung presentation? Was the use of medical jargons, technical words adequately explained? And finally, contributions to new perspectives and knowledge on managing various key COVID-19 health issues. Thank you to the 120 plus people who are keying in their answers. And as always po, we have strong agreement from our attendees with regards to the level of reception that they got for this particular webinar and how they learned a lot from the panel discussion.
Okay, we're going to ask all our panelists to have a very short parting message, and then Chancellor Menchit Padilla is going to do the closing remarks. She needs to leave immediately. But I'd like to also acknowledge the presence of Dean Charlotte Chong of the College of Medicine of the University of the Philippines, and also to Vice President Nenny Pernia, UP Vice President Nenny Pernia, who is also with us on the webinar. So we'll start with Dean Fontanilla. Dino, what's your parting message?
Parting message. One, I think with everything that's ongoing right now, all this crisis, I think it's good to see that we have collaborative work like this webinar. I think that is something that we have to really push forward. No, it's only through collaboration that we can win in the end.
Thank you very much, Brent. Parting words from Brent.
As what I've said a while ago, we should always have access for everyone, not only because we are sick, but also because it's our right to have access to everything. Amidst the crisis, amidst the pandemic, we should always have access to everything.
Thank you very much. Doc Noneng.
Raymond, yung siguro dun sa survey questions lang, I think if anyone answered number 2 for Crohn's disease, it's also true that it's a pre-malignant condition. And parting words is a surgeon should be at the top of his game during this pandemic, meaning you should really treat your patient very well, conscientiously, and decisively in terms of surgical intervention. And I'm very proud that UP, PGH is true to its mission of service to particularly our poor patients, because we never closed in terms of emergency servicing our emergency surgical patients, and now we're resuming up and ramping up our elective surgery patients too. Thank you.
Thank you, Dr. Monroy. Dr. Boc Ocampo.
Yes, I have 3 words that always guide us in our operation. Those are safety, science, and solidarity. Thank you again for this opportunity.
Maraming salamat po. Ma'am Cecil Peña, yes.
Good teamwork is definitely essential in any healthcare situation. And I would say that doctors and nurses are really very committed to the work that we have been given. Thank you.
Thank you very much. Okay, our closing remarks will be by Chancellor Menchit Padilla.
Okay, so allow me just to give the highlights of today's grand rounds. So in pre-COVID times, this could have been an ordinary case, but COVID-19 changed the perspective on the patient. And Dr. Viray and Dr. Monroy recognized the challenges in March, and that was the delay in management and the gap in the coordinated transfer. And what I'd like is what Dr. Monroy was saying, both Dr. Monroy and Dr. Viray saying that the tenet in management is the same. You do not delay the surgery. But during the pandemic, we've got to do the PCR. We've got to protect the surgical team. We've got to give the best, the most senior resident, so that there will be minimal blood loss. And we've got to explain the well-added risk of COVID. I've learned something new today. You know, I belong to the generation of no CT scan, but how valuable technology is. And we can actually do this if proper referral is actually done. Dr. Bog actually gave a scenario where if this patient was admitted today, things would have been different. And I think that's what we have to remember now, that because we have learned in the past 6 months, as Dr. Bog Ocampo said,
If this patient came to the hospital now, because of the one hospital command, there will be no problem with the inter-hospital transfer. Second, he said that because we can release results in 3 hours now, there will be no delay in the surgery, there will be shorter stay at the ER, and there will be no panic among the clinicians and the patients when a patient is actually operated in the right ward. And maybe a practice that I'd like other hospitals to consider is the use of the testing of the watchers, because you're right, it's not just the patients, it's actually the watchers. I'd like to thank Cecil, Deputy Director for Nursing na Cecil, highlighting the role of the nurse. And today we heard the role of the community nurse and the hospital nurse. We only talk about the patient, we only talk about the doctor, but as you've heard from Deputy Director Cecil, in every step of the life of the patient in the hospital, we had the nurse. So allow me to just end with a few statements I picked up from the group, from Cecil, from Deputy Director Cecil. She said, a nurse will touch every day, a nurse will touch a life, or a life will touch the life of the nurse. From Dr. Boco Campo, he said, PGH continues to be flexible and proactive, and in the time of the pandemic, we must all be flexible and proactive. But allow me to give the last statement, which I picked up from Dean Fontanilla. Dean Fontanilla said, during this pandemic, this is the time to work together, to share ideas, and to learn from each other. And that is the purpose of the virtual Grand Rounds. Good afternoon to all, and thank you for joining us.
Thank you very much, Chancellor Menchik Padilla of UP Manila. Next week, be with us on Friday. We have a very interesting case. This is going to be a mental health story. It's about someone who wanted to take her life because she could not cope anymore with COVID. So be with us next Friday, and thank you for joining us this webinar. Raymond.
Thank you to our esteemed panel of speakers, and thank you for that inspiring closing remarks, Chancellor Padilla. We also have our post-test questions for those who were not able to answer. Please feel free to review them, and the answers po were already given by Dr. Brent Viray and Dr. Noneng Monroy. So maraming salamat po. Before we close, let me just give a shout out to our regular attendees po, all the way over from the Region 2 Trauma and Medical Center, Bayongbong, Nueva Vizcaya, Cagayan Valley, from Valladolid District Hospital, Negros Occidental, Western Visayas, from Zamboanga del Sur Medical Center, Pagadian City in Zamboanga Peninsula, from the DOH Treatment Rehabilitation Center, Malaybalay City in Bukidnon, Northern Mindanao, the Tibo Cure Hospital in Island Garden City of Samal, Davao Region, and internationally, we continue to be watched and viewed, especially for this webinar from the Dr. Sulaiman Al Habib Hospital, Al Suwaidi, Riyadh, Saudi Arabia, from the Niagara Falls, Ontario, Canada. So maraming salamat po sa lahat-lahat po ng naka-tune in. And as always, inaanyayahan po namin po kayong lahat na mag-tune in po to our regular Friday habit po from 12 noon to 2 p.m. Next week po, we will have a mental health case study that we will be talking about, and we hope a lot of our viewers will still continue to watch and register because it's an exciting topic overall. So maraming salamat po. Keep safe, keep healthy, and see you online.
The enemy remains unseen. I'll keep your hand in mine. Let's say a prayer one more time. I know you long for home, but I am here, you're not alone. I'll stay with you until the coast is clear. The others pain before my fears, the others laugh before my tears, but right behind the mask, I look into myself and ask, do I have strength to carry on? My God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. Just look into my eyes and say his name to realize it's fine to be afraid. Just hold on to the word he gave. This time will come to pass, 'cause this salvation's made to last. He'll carry you to see the break of day. The others pain before my fears, the others vows before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. The others pain before my fears, the others vows before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'll keep my word, your word is mine. The others pain before my fears, I'm pushing on despite the tears. Please take us through another day. Just hold my hand, I will hold the line. I will hold